Good morning, everybody. I have nothing to disclose in relationship to this presentation. And what I would like to do is to walk you through the vision that we can gain through MRI, how we can visualize, how we can quantify, how we can monitor some of the mechanisms that Tanya, Professor Kuhlmann, explained us before. This is a brief outline of what I would like to say. We will start with a recap about why we are so interested in clinical worsening in MS, what advanced MRI can give us, and then conclude with many perspectives. So as Tanya mentioned before, I liked a lot this figure because it shows what the past was, where we had clinical worsening, mainly we thought triggered by acute inflammation, relapses, new lesions, and you see it on the top. And then nowadays, also thanks to the treatment that we have that masked this effect because we managed to strongly reduce these acute inflammatory events, we see that there is something else. We see that patients are still worsening clinically, and this is most probably due to different mechanisms, as Tanya explained us before. And just to give you the sense of how much, so why is it so important, how much I was speaking about? We have registry studies that tell us that PIRA, progression independent of relapse activity, is present in more than 60% of the patients. And we have also clinical trials that show us that the percentage can be even higher in relapsing, remitting MS patients. So what does MRI bring us? What can we do? You see this, I always say I like these pictures because they're colorful, they're beautiful, and they're powerful. They're powerful because they provide us with these biophysical measures of tissue properties, which means we can quantify what's happening in the brain. We can do it with pathology, but in this case, we do it in vivo in MS patients. And this is our imaging people overview of different mechanisms that we can image. You see here is a very visual summary. We have mechanisms related to focal pathology. We will see a couple of them. We have mechanisms related to normal appearing tissue pathology. We have heard already what's happening in there. We have mechanisms of exhaustion of functional reserve, functional and structural, and I think Professor Hundheim, did I say it correctly, will tell us a lot about this, so I will not speak about that. And there are mechanisms of general neurodegeneration. And I would like to start speaking about these famous chronic active lesions that we call pearls, but they're not only pearls. And recap, that's what Tanya showed us before. That's a typical normal understanding we have of these lesions. There are lesions with, let's see if I'm coordinated enough, lesions that lack of myelin. I mean, you see up there, the staining, the brown staining is myelin, the lesion is lacking myelin, is completely white. And around the lesion, there is this violet border, which are these myeloid cells, so microglia, macrophages. Sometimes they're rich in irons, we have heard, and this is the characteristic that we use to image them. And they're interesting because they trigger demyelination. You see there the MVP staining, where there is loss of myelin at the border, and it trigger acute axonal degeneration. We can see these lesions if they're rich in irons using quantitative susceptibility maps. And now you start the video, it's a collaboration, perfect. So this is the brain of an MS patient. You see the lesions, you see in red the lesion mask. And now we focus on that lesion, which appears in a QSM map having this white rim, and this is iron. But the most interesting thing is that if you use a myelin map, this lesion is completely blue, which means completely lack of myelin. And in an axon map, MRI axon map, do you see the bluish core and the surrounding, which is a bit less bluish? This is lack of axons. And then if you go to the quantification, which we can do, use the same parameters that I told you before, myelin water fraction, which is a surrogate marker for myelin, and NDI, which is a surrogate marker for axon. You see that these lesions that we call nicely pearls, they have less myelin-related and less axon-related quantity compared to the other lesions. This is a fact. And then in a study that we did some years ago between Lausanne and Basel, we also saw that in patients having zero clinical activity and zero MRI activity during the past year, so our stable patients, if you count these lesions and if the patient happen to have 2 or more of these lesions, this is the main determinant in this multivariate model of the increase in the serum of this patient of this serum neurofilament light chain, which is a neurodegeneration biomarker. So only 2 of these lesions, which was impressive. And further, these are all studies from the Swiss MS cohort. Further, we have understood that the percentage of patients with 1 PRL or more is higher in progressive MS patients compared to relapsing remitting MS patients, and it's also higher in PIRA patients compared to stable patients. And this holds true also if we consider only relapsing remitting patients, which is, again, impressive. This is 1 or more. And then, of course, people are discussing what is the best threshold, how many pearls do we need to have to say this patient will progress. This is a meta-analysis. It's not perfect. They tried to put together studies that have been published with different results. Some people say 1, some people say 2, the majority say 4. And indeed, the more you have, the more it's predicting of clinical worsening. And the second factor which is influencing is the follow-up period. And it seems that if you have a shorter follow-up period, there is a higher relationship with clinical worsening than in a longer follow-up, which is also interesting. And it's interesting, and then we came back. These are new data, not published data. We presented them at 2 different conferences, at ACTRIMS and ICE-REM. It's a work of Alessandro Cagol, who should be in the audience. What we realized, and that's perhaps connected to these broad rim lesions, is that these pearls, also the one that you can see, which are a subgroup of the total chronic active lesions, but they are not all the same. They are different, and you can cluster them. There are essentially 2 clusters. You see them, the orange and the blue cluster. And if you look at these microstructural biophysical measures that I told you before, in these 2 clusters, you see that they are different. That's why we called one cluster, because this is what measures are telling us, high damage PRL, and the second cluster, low damage PRL. So this is, again, the imaging point of view. And then you do correlations, and you realize that the low damage, so the presence of low damage PRLs, where is the low damage PRL? Is here, is correlated to serum neurofilament, the second graph there. Whereas the presence of this high damage PRL is correlated to the EDSS. And further, even more interesting is when you look at the follow-up. This is, again, Swiss MS cohort. We have this long follow-up. So the presence of this low damage PRL is correlated to EDSS increase, so clinical worsening over time, the low damage, increase of GFAP and increase of SNFL over time. What does it tell us? So this gave me a lot of hope, because in all these pharma boards, when they try to get as an outcome these PRLs, they're all puzzling. What do we take? More than 1, more than 2, the number. Or do we take the volume? None of them. What we need to look at is the microstructure, and these are the data that are supporting that. And perhaps, now we're looking at the extent of the iron rim in this low damage to see if there is a relationship to these broad rim lesions that were described. And more, there are not only PRS, there are other iron-enriched lesions and areas. This is something that was discovered post-mortem by Riccardo Galbusera, who has now finished his PhD. He observed that some lesions have this half a moon there of hyperintensity, which corresponds again to activated microglia and macrophages. And interestingly, they are always below an area of the cortex which is completely demyelinated. Then he went to the Swiss MS cohort, he saw this sign that he called GPR, also in vivo, and then he did all this very complicated stuff to say that there was a correlation between the presence of this sign and cortical lesions, which is important for us because we know that cortical focal pathology is related to clinical worsening. And again, unpublished data, but there was an oral presentation at ACTRIMS. What he saw in many SMSC patients is that people with this GPR had a higher MSSS, which is EDSS plus disease duration, compared to people without. So also this seems to be, it's present more or less in 8%, 10% of the patients, is a sign that is related to disability and clinical worsening. And then this myelin axon loss and repair. I will look at repair because I'm a positive person. And we start with another video. Can you start the video? Voila. So this is what we know we have already seen with the bad lesions, and this is another brain where I want you to focus on another lesion, this one, the red one. And you see this lesion, if you look at the QSM map, we don't see it. It's iso-intense. And now if you look at the myelin map, you see that it's greenish, it's not as bluish as before. So the myelin content is less, but not too much less. And the same holds true for the axon content. This observation let us investigate these lesions. It's the same for lesions that are a bit blackish, which we call hypointense. So these iso-hypointense lesions behave like this. And we quantify it. So these are the lesions in the two boxes, again with these measures, myelin-related and axon-related. And you see that these lesions, compared to all other lesions, they have higher content of myelin and higher content of axons, which let us hypothesize that those are, if you start the little videos there, this is post-mortem experiment, that those are remyelinated lesions. So we do this post-mortem experiment. This is a 3D printed brain box that helps the pathologists cut where we want them to cut. It's pretty good. You have very good matching. And then in the end, we understood that if the lesion was iso or hypointense, we had 100% specificity for remyelination. So now we can quantify remyelination that has occurred. And look at this. This came in last night, unpublished data from the SMSC. There seems to be a correlation between the proportion of these lesions over the total lesions, so how many lesions remyelinated, and EDSS. So that the higher the proportion of this lesion, the higher the repair activity based on this biomarker, the lower the EDSS. Makes sense. And the interesting thing for me is that if you use another method, always based on QSM, but also quantitative T2, this is chi separation, you get from these QSM images two maps, myelin and IROMAP. And then we quantified the changes in myelin in lesions over 2 years. You see baseline and 2 years follow-up. This is a subgroup of the SMSC. We quantified this per lesion, and then we made a plot of median changes in myelin between baseline and follow-up and changes in EDSS in the patients. And we saw that there are patients that are progressing, they're getting worse. There are also patients who are getting better over time. And if you look at the patients getting worse, you see that there are all these columns which are lesions changing over time. And in red are the lesions that are decreasing myelin, and in green, lesions that are increasing myelin with these maps. And on the other side, you have examples of patients. This is the study of Janis Müller, who's also here in the audience. In the other part, there are the improvers, the ones who get better. And again, in red, the bad lesions, and in green, the good remyelinating, so myelin, lesions that are increasing myelin over time. And what do you notice is, again, that the proportion of lesion seems to cluster with the clinical behavior. And again, different approach, same results. This is totally different approach. We used MT-SAT and multi-cell diffusion to get myelin water fraction. You see this red map up there, and axon volume fraction, the green map. Then we look at the behavior of this parameter over time and their combination. So that we said, for this lesion, there is a pattern related with repair. For this other region, there is a pattern related to damage. There were some mixed patterns and some stable patterns. We classified the lesions like this, and what we found again was the same thing, that the proportion of lesions, of damaged lesion was correlated positively with the EDSS, so the higher this proportion, the higher the EDSS, and vice versa, that the proportion of repaired lesion was inversely correlated to the EDSS. It's the same concept with 3 different approaches. And then I would like to show you a bit of normal appearing tissue. Again, these 2 maps, myelin water fraction and NDI, again, a subgroup of the SMSC. And what we found, this is tissue excluding lesion. Nothing. We took away the lesions from the maps, both in gray and in white matter. And this is the result. So in white matter, of course, both. In white matter, you see, let's see if I can coordinate. On the top there, you see the statistical maps showing you the differences between patients and controls in white matter. They're different, and that's it. But we didn't find any differences between progressive and relapsing remitting patients. Nothing in the white matter. We did find this in the gray matter. So that's the difference between patients and controls, and this is the difference between progressive, relapsing-remitting patients and controls, and you see that there are differences, although we took away the lesions that we saw using a certain methodology. So the cortex, again, what Tanya told you before, seems to be related to progression. And now like this. And this is one of the few studies that is not from the SMSC, but just to show you that it's not only the progressive definition that we need to use. There are different types of symptoms and signs, and I think Menno will speak a lot about this. So this is a study from the Milano group showing that some microstructural parameters explained the global cognitive deficits in these patients in a test-retest type of experiment. Again, extracting the microstructural properties of the normal appearing tissue, excluding completely the lesions. But I think Menno will speak much more about this on the next. And then I would like to confuse with the diffuse neurodegeneration, which means we don't take out the lesions, we focus on the global changes from an imaging perspective in the brain and in the spinal cord. And again, studies from the Swiss MS cohort. The first one is the one that showed that we wanted to look at these tracts, white matter tracts that we can image. And you see here, not all the centers have this DTI protocol, so we used the data that we had. We analyzed these 3 parameters. We did this propensity score matching between patients with PIRA and without PIRA. And then we analyzed 2 main tracts, the corpus callosum and the corticospinal tract. And the results are this. It's pretty simple. These are in top, the corpus callosum, on the bottom, motor tracts. The PIRA patients are in yellow. They show overall, everywhere, microstructural damage compared to stable patients. And then the cortical atrophy, you have seen already these slides before. This is, again, the patient cohort from the SMSC, the comparison between PIRA and stable patients. We checked the global and regional atrophy rates. And this is when we compared relapsing, also relapsing patients show atrophy. This is clear. This is relapsing versus stables. They showed atrophy in the cortex, but also in the deep gray matter compared to stable patients. And in the cortex, where it's blue, it's bad. Where it's blue means decreasing volume. But if you look at the comparison between PIRA and stable patients, it's much more blue, and only in the cortex. Again, telling us that in vivo, in a MS patient, this cortex damage is very important. And this holds true even, that's a reviewer who asked us this, even if you consider the subgroup of patients without any radiological activity, not only the clinical one. And last, the spinal cord. We always forget the spinal cord. It's not so easy to image the spinal cord. We don't collect it in the SMSC, but we have the brain. And the brain images are coming down to here. So you see that we can analyze a little piece of the spinal cord, which is enough. This is the C2, C3 cross-sectional area. And we found, again, that this C2, C3 spinal cord area is reduced in progressive MS patients compared to relapsing remitting, expected, but also in PIRA versus stable, and also in the PIRA versus stable in the RRMS subgroup. So the fact is that this patient have cortical loss, the spinal cord loss, and diffuse white matter damage. And then you try to do a lot of things. It's also possible to predict the volume of the spinal cord at baseline, the volume of the brain, and the volume of the cortex predicts the development of PIRA. So if you have less, you are more prone to develop PIRA, which makes sense. So to conclude, I hope I showed you the clinical worsening in people with MS in vivo depends on many mechanisms, some of which we can image. That in vivo quantitative MRI can give us this view over mechanisms that we can quantify and better understand the relationship to the clinic of this patient, that we can identify subgroups like this one with the pearls and the low microstructural damage that most probably highly benefit of a therapeutical intervention because we can prevent what's happening, and that the SMSC was pivotal in reaching all these results. So those are all SMSC studies but one. And then there's still a lot need to be done, and we need to be bold because there's so many things that we can image and that we'll do. And like this, I would like to thank the imaging group in Basel, the big RC2MB in Basel, but also the big neurology department in Basel, and all of you, because this is the SMSC. And thank you all for your attention.